Thank you, Wilfred. It's my pleasure to summarise 3 important trials that were presented here at Heart Failure 2026, which, in addition to the decision trial that we just heard about, are also major highlights of the conference. The first is a sub-analysis of the DIGIT-HF trial, which randomised 1,212 patients with heart failure to treatment with digitoxin or placebo, and found a positive impact of Digitalis on the combined endpoint of all-cause death or first heart failure hospitalisation. There were 330 patients with atrial fibrillation and 882 patients in sinus rhythm. While the formal interaction analysis was negative, the impact on outcome was more pronounced in patients with atrial fibrillation, with a hazard ratio of 0.72 as compared to a hazard ratio of 0.86 in patients with sinus rhythm. This was mainly driven by all-cause mortality and led the authors to conclude that digitoxin has favourable effects in heart failure independent of atrial fibrillation status, but that it may confer particular benefit in patients with heart failure and atrial fibrillation, a high-risk population. Secondly, the SUBCUT-HF2 trial randomised 172 patients admitted to hospital with heart failure who needed intravenous diuretics to either receive usual care or to early discharge with continuous subcutaneous administration of furosemide via a wearable mini pump. The primary endpoint, the number of days spent alive and out of hospital from randomization to 30 days, was significantly greater by 4 days in the early discharge group. The length of the index hospitalization was also shorter at 5.6 days versus 11 days. Quality of life at 60 days did not differ between the groups. This study potentially highlights a new care pathway for patients with decompensated heart failure. Thirdly, the multi-centre REDOX-AHF trial randomised 134 patients with acute heart failure, dyspnea, and a clinical need for oxygen, or an oxygen saturation below 92% and signs of pulmonary congestion, to liberal oxygen therapy, targeting more than 96% saturation, or to a restrictive oxygenation target of 90% saturation. An automated oxygen delivery device allowed for a double-blinded design. Between admission and day 1, the restrictive strategy led to a significantly greater reduction of estimated lung fluid content, a measure of decongestion. Patient-reported dyspnea and respiratory rates were not different between the groups, while the number of days alive and out of hospital at 23 versus 21 was significantly higher in patients randomized to the restrictive strategy. The trial confirms guideline recommendations to prefer restrictive oxygen targets over liberal oxygen use in patients with acute decompensated heart failure.